Medicine's a bit of a family disease for us. My sister's a doctor, my father's a doctor, his brother was a doctor, my father's father was a doctor, his brother was a doctor, and my great grandfather was also a doctor. So medicine was always around as part of conversations growing up, and it just seemed a natural fit. One of the advantages of being in a medical family is that I knew that it was going to be hard at times. And medicine's a great career. We get to see people at their best, but it's complex, difficult, but rewarding. And so pretty much it's been that. It's difficult, complex, rewarding. There's the opportunity to work too hard. In fact, there's too many opportunities to work too hard. But that's because the career is so immersive and enjoyable. So it still wasn't a bad decision, I think. I'm still enjoying myself. And I suspect I'm going to enjoy myself in medicine and surgery well out into my 60s and 70s. My mum was browbeaten to retiring from her work at the age of 82. And so if I'm still going to work at the age of 82, contributing and happy, I think that's a great outcome. When I started off as a junior doctor, one of the advantages of being a junior doctor is you move from place to place. You get to do all sorts of things: surgery, emergency department work, medical work, psychiatry. You get exposure to general practice, and it's all actually fascinating, and all of those jobs would have been fantastic opportunities to work and get a career. The thing that drove me most to surgery really is that combination of complexity in learning skills, immediacy in understanding whether what you're doing is working or not. So you get instant feedback about how things are going, and not just being a surgeon, like being a technician, but the combination of doing surgery and complex medical work. So a lot of the conditions that I treat don't just have complex technical surgery associated with it, but complex human biology and physiology. So it's technically as well as intellectually challenging, and there's a lot of work that goes into assessing people, assessing their psychology, assessing their physiology in order to make good decisions for them about what therapy to offer them. Because most of the diseases we treat, be it obesity or reflux or hiatus hernia or body wall hernia or gallstones, there are multiple different options. How do you try to find the best fit for that person with all of the multiple options? And that part's really enjoyable for me. You know, it's a jigsaw puzzle when somebody comes in and you're trying to assemble the correct pieces for them to get the outcome that they want. When I started in general surgical training, we get to do a whole lot of different types of general surgery, as well as exposure to all the other surgical types. In the end, the decision for me about upper GI surgery was that at the time when I started, it was obvious that this was the hardest of the specialties because the surgery was very complex, but also it was obvious that there were just over the horizon a whole lot of new technologies which were going to arrive in this space that I'd then have to learn. So it was that combination of complex surgery, complex patients, and the opportunity to be ready when new technologies and new procedures became available. So while I was training, bariatric surgery, for example, didn't exist in any meaningful way in Australia. But I could see from looking at the literature and speaking to my overseas colleagues that it was frequently done and very successful overseas. So what I wanted to do was to have the opportunity to be there at the beginning of something as it's starting and immerse myself in it. So a couple of the areas where I've been able to be there at the beginning and really get my teeth into the things are bariatric surgery, using keyhole surgery rather than open surgery to treat cancers, robotic surgery. So I did the first upper GI and bariatric robotic cases in Australia with the Da Vinci intuitive system, and I've also done the first upper GI and bariatric cases with the Medtronic Hugo robotic system. I also really liked the new technologies that were available in endoscopy, and so was one of the only surgeons in New South Wales using endoscopy to treat early esophageal and gastric cancers. When I started out in 2003, I'm one of the only doctors in New South Wales who does different treatments for a condition called achalasia. I do it endoscopically and surgically, whereas most surgeons do it one way and gastroenterologists do it another. So it's nice to have both options.
Good.
With regards to managing complex patients with reflux, we started the first high-definition esophageal physiology lab in New South Wales. 2008, there was a massive change in esophageal diagnostics, with simple tests producing really small amounts of data to complex tests producing really large amounts of data. And the opportunity to be at the start of that was also fascinating, because not only has it allowed us to understand patients better, to offer them a wider range of treatments, but it's also been a fantastic education about how these technologies help patients and evolve over time. So a lot of really interesting things going on. And so I could see these things were happening because I picked it up in my training, and it's borne out to be true. Upper GI surgery still is a really good way of getting complex technical work, new innovations that keep on coming in year out, and really interesting patients with interesting problems and interesting problems to solve, and satisfying patients to look after. A lot of our patients that we treat spend months or years with significant disabilities and functional problems, and if you get their treatment right, they can go from being disabled to not disabled quite quickly, and they get on with their lives like they want to.